My name is Jenna Pawnette, and my image analysis project is on the ankle and calcaneus. For the AP ankle, the part position needs to be in true lateral with the foot dorsiflexed. The central ray is perpendicular to the ankle joint midway between the malleoli, and the collimation is going to be 1 inch on the sides of the ankle and 8 inches lengthwise to include the heel. Here I have labeled the anatomy, which includes the fibula, tibia, fibular notch, medial malleolus, lateral malleolus, and the talus. The evaluation criteria includes the ankle joint being centered to the exposure area, the medial and lateral malleoli visualized, the talus is visualized, as well as the tibio-talar joint space, and there's going to be no rotation of the ankle. On the left, this image meets evaluation criteria, and on the right, it does not because the talus is not superimposing over the distal fibula. The next projection is the AP oblique ankle with medial rotation. The part position is the IR centered to the ankle joint. The foot is dorsiflexed and it is internally rotated 45 degrees. The central ray is perpendicular between the malleoli, and the collimation is the same as the AP. The anatomy included on the medial rotation of the oblique ankle is the tibiofibular joint, lateral malleolus, medial malleolus, talus, calcaneus, and the base of the fifth metatarsal. The evaluation criteria for this is the ankle joint is going to be centered to the exposure area. The distal tibia, fibula, and talus are visualized, and it needs to be a proper 45-degree rotation of the ankle. The image on the left does not meet evaluation criteria because the ankle is over-rotated and the collimation is improper. The image on the right does meet evaluation criteria. This is my favorite projection of the ankle, and it is the Mortise. The part position is same as all the others. The ankle is going to be centered to the IR. We're going to internally rotate the entire leg and foot 15 to 20 degrees, and the plantar surface of the foot is at a right angle to the leg. The central ray is the same as the AP and medial oblique ankle, perpendicular between the malleoli, and the collimation is the same. I've included this question into my PowerPoint, and it is, what plane is parallel with the IR during a Mortise ankle projection? A, intermalleolar plane, B, mid-sagittal plane, C, mental meatal line, and D, mid-coronal plane. The answer is A, intermalleolar plane. The anatomy included for the Mortise ankle is going to be the Mortise joint, the talus, medial malleolus, lateral malleolus, tibio-talar joint space, and tibiofibular joint space. The evaluation criteria for the Mortise is it's going to be centered to the exposure area. The distal tibia, fibula, and talus are visualized, a proper 15 to 20 degree rotation of the ankle. The image on the left meets evaluation criteria, but the image on the right does not because it has very inadequate collimation and the foot is not dorsiflexed, and you can tell that by the Mortise joint not being completely open. This projection is a lateral ankle. It is a medial lateral projection. The patient is rotated on the affected side. The long axis of the IR is parallel with the long axis of the leg, and the foot is going to be dorsiflexed, in which ensures that lateral position is achieved. The central ray is perpendicular entering the medial malleolus, and the collimation is the same as all the other projections. For the lateral ankle, the anatomy included is the tibia, fibula, talus, talar neck, talar head, navicular, calcaneus, posterior talar process, and posterior tibial process. The evaluation criteria for the lateral ankle is the distal tibia and fibula, talus, calcaneus, and adjacent tarsals are visualized, and the fifth metatarsal base and tuberosity should be seen to check for a Jones fracture, and the ankle is going to be in true lateral position. Another question I have is, what bone is superimposed over the posterior half of the tibia? A, patella, B, femur, C, fibula, and D, talus. The answer is C, fibula. The image on the left does not meet evaluation criteria because the foot is not dorsiflexed and the collimation is improper. The image on the right does meet evaluation criteria. For the AP ankle weight bearing method, it's pretty much the same as the AP except the patient is going to be placed upright. and the IR is going to be behind the ankles, and the patient stands with the heels touching the IR, and the toes are going to be pointed straight. The central ray is perpendicular to the center of the IR, and the collimation is the same. My last question I've included is, why is the weight-bearing ankle done? A, to see if the foot is in place. B, to better visualize the tib fib space. C, to identify ankle joint space narrowing. Or D, to determine if it is the left or right ankle. The answer is C, to identify ankle joint space narrowing. The anatomy included for the weight-bearing ankle is the same as the AP ankle. The evaluation criteria for weight-bearing ankles are both ankles are going to be centered on the image, the medial Mortise joint is open, the distal tibia and talus is partially superimposed over the distal fibula, and the lateral Mortise is closed. The image on the left meets evaluation criteria, but the image on the right does not because it is not marked and the patient was not standing straight over their foot. Moving on to the axial calcaneus, the planto-dorsal projection. The part position, the IR is going to be under the patient's ankle, and the patient is going to hold the ankle in dorsiflexion. The central ray is 40 degrees cephalic, entering the long axis of the foot. It's going to enter around the base of the third metatarsal. The collimation is 1 inch on 3 sides of the calcaneus to include the 5th metatarsal base. The anatomy included on this projection is the base of the 5th metatarsal, trochlear process, lateral process, calcaneus, medial process, tuberosity, subtalar joint, and the sustentaculum tali. The evaluation criteria for this is the calcaneus and talocalcaneo joint is visualized and that there is no rotation of the calcaneus. The image on the left meets evaluation criteria, and the image on the right does not because the calcaneus is not adequately penetrated at all. The axial calcaneus, the dorsoplantar projection, has the patient lying prone on the table. The ankle is going to be elevated and the ankle is going to be dorsiflexed, so the long axis of the foot is perpendicular to the tabletop, and the IR is going to be placed on the plantar surface of the foot. The central ray is the same, except it's going to be a caudal angle entering the dorsal surface of the ankle, and the collimation is the same. The anatomy included on this projection is the trochlea, sustentaculum tali, the lateral process, and the tuberosity. The evaluation criteria for this projection is the calcaneus and talocalcaneal joint is visualized and that there is no rotation of the calcaneus. The image on the left does not meet evaluation criteria because the foot is rotated and the talocalcaneal joint is not visualized. The image on the right meets evaluation criteria. For this projection, the lateral calcaneus is a medial lateral projection. The patient is going to be rotated on their affected side. The part is centered to the IR. The central ray is perpendicular to the calcaneus and 1 inch distal to the medial malleolus, and the collimation is 1 inch beyond the posterior and inferior shadow of the heel. The anatomy included on this projection is the sinus tarsi, navicular, cuboid, calcaneocuboid joint, tuberosity, and the sustentaculum tali. The evaluation criteria is the entire calcaneus is included with the ankle joint and adjacent tarsals, and that there is no rotation of the calcaneus. The image on the left does not meet evaluation criteria because the foot is not dorsiflexed, but the image on the right does meet evaluation criteria.